this is an important question in this context, in the current context where we aim to design clinical trials dedicated to high-risk myeloma patients, but also to adapt treatment to risk in routine practice in these high-risk patients. We must define them as accurately as possible, and if possible, from the diagnosis, because we have the minimal residual disease helping us to identify, I would say, functional high-risk myeloma, but we need also to have this information from the diagnosis. And we have a different system of stratification. And of course, given the major impact of cytogenetics, the revised ISS has included 3 abnormalities 7 years ago: the deletion 17p, the T14 and the T14-16, along with the LDH level, where a high-risk patient is defined by ISS3 and either high-risk cytogenetic, either LDH. So this means that a patient with deletion 17p and without ISS3 is not defined as high risk. So several teams have questioned the discriminantability of this revised ISS, notably because of the extremely large heterogeneity of intermediate patients, RISS2, for whom the high-risk cytogenetics remain highly prognostic. So other staging systems have been recently developed to try to improve risk assessment, in particular the IFM score, which is purely cytogenetics based on 6 abnormalities. We also have more recently the revised 2 ISS proposed by the European Myeloma Network. And we also have the Mayo additive staging system, the MAS. These scoring have 2 things, I think, in common when compared to the revised ISS. First, they include 1Q gain, which is associated to shorter survival and involves 1/3 of newly diagnosed patients. The IFM score also includes 1P deletion, which is not as frequent, but a strong prognostic factor. And the second thing in common it is that these scores are based on the fact that independent cytogenetics factors are cumulative. This is a crucial notion. The more factors to which a patient is exposed, the higher is the likelihood of having a worse outcome. So this is a very important notion to have in mind. Of course, there is some debates between these staging system, the cutoff value for deletion 17p. Is it more than 50%? I do think so. The prognostic impact of the number of copies of 1Q gain, 3 or more than 3. And of course, the debates about the T14-16, which is not included in the IFM score, nor in the revised 2 ISS.